Welcome to the Obesity Medicine Podcast with your host, Dr. Matea Rentia, board certified in internal medicine and obesity medicine. Here, we talk about a path to metabolic health, and we have real conversations about chronic weight management and living a full life. Just a reminder, I am a physician, but I'm not your physician. So everything that's on this podcast is for informational purposes, but please go talk to your doctor about what's right for you. There is no medical advice being given on this podcast. Welcome back to another episode of the podcast. Today, I am super excited. We have Dr. Nishant Kumar. He is a board-certified psychiatrist and addiction psychiatrist. And you came highly recommended to me from a good friend and colleague of mine, and she said you need to get him on the podcast. So before we start talking, can you just briefly introduce yourself just so that everybody knows a little bit about who you are and how you help patients?
Absolutely. Thank you for having me on. My name is Nishant Kumar. I'm board certified in psychiatry and addiction psychiatry. And I work with adults with just primary mental health issues and psychiatric conditions. But I also work with adolescents and adults who may have just a primary substance use problem. And that could also be drugs or alcohol. It could also be behavioral addictions, food addictions, other compulsions as well. And then we have a large majority of our patients who really struggle with some element of both, whether it's a co-occurring mental health issue and or a behavioral or substance use problem. That's mainly the kind of population that I work with currently.
Amazing. You brought up something when we just started talking. I was like, wait, we got to hit record.
Yeah.
I did not understand really the difference between there's addiction medicine and then addiction psychiatry. So can you tell us a little bit about what physician can go into each of those? How does that work?
Sure. Absolutely. So if anyone's seeking help with a substance use problem and they're looking for a specialist, they'll usually look for a physician with some sort of experience, credentialing, or board certification in the addiction field. Now, the addiction field is separated out where there's addiction psychiatry. The way a physician gets to the addiction psychiatry fellowship and board certification route is they have to have completed 4 years of a psychiatry residency. And then they have to opt in for 1 year of an addiction psychiatry fellowship. And then they have to sit for both board exams. And it can be boarded in psychiatry and then addiction psychiatry. When I started my career, I also took the additional step to then study for and apply for the addiction medicine boards, which is slightly different. It's more heavy on the medicine side, managing blood pressure, other things, whereas the addiction psychiatry is really looking at like mental health along with substance use problems. If a physician wants to go the addiction psychiatry route, yes, they have to first start with the psychiatry path in residency. Now, the addiction medicine, which a lot of non-psychiatrists will pursue, and those can be family practice doctors, those can be internal medicine doctors, pain management doctors, anesthesiologists, because they have some interest in wanting to incorporate that sort of treatment into their practice and help patients with substance use problems. And they will usually then either complete an addiction medicine fellowship or they'll complete the requirements in order to sit for the board exam and obtain that certification.
Thank you for clarifying all that, because it's always fascinating how complicated it all is. I think people don't realize when you're coming off of a substance. I know I'm internal medicine, and oh my gosh, when we had people on the wards that maybe alcohol was involved, something like that, there's a lot you have to, it is actually life-threatening, everybody who's listening. This is not just, okay, they're in here and we're dealing with other problems. And so it's just thank you for you and everyone that takes care of this area, because it's really complicated with addiction. One of the reasons I brought you on, a lot of my people that are listening or patients in my world, they're on GLP-1 medications. And I want to hear your thoughts about how you see GLP-1s, what kind of influence it's having in the addiction world, whether it be with, you talk about a lot of different areas, but whether it be food addiction or alcohol use disorder, how are you seeing the GLP-1s start to influence what's happening there?
Yeah, we're seeing it quite a bit because I work for a large medical system where we have primary care and internists involved managing medical issues, but then they're seeing specialists like myself for either substance use or addiction issues or mental health issues. So when there was the big wave of sort of approval and introduction of these GLP-1 medications, I started to kind of see this pattern in patients just self-reporting that, doc, I just don't feel like drinking alcohol anymore. And nothing had changed with their life, with events, with stressors, with therapy, with groups, with other medications or their mental health symptoms. They just no longer felt a desire to pick up that drink. They never didn't think about it as much, or the pleasure from coming from drinking just was no longer there. And that was an effect that we didn't see to that degree that we have with current FDA approved medications for things like alcohol use disorder. A lot of my patients who either have either a mild, moderate, or severe alcohol use disorder specifically started to go into either early remission, meaning they had 3 months without a drink, or sustained remission, a year without a drink. And those who had maybe just problematic use, they were probably drinking more than they wanted to, didn't really meet criteria for a substance use problem. But they realized, yeah, those 2 drinks I'm having every day, probably not the best for my health, probably not good for my mood, probably not the best for my sleep. They on their own just said, yeah, that went away, or it's gone down significantly. I don't think about it. I don't want it. The desire, the urge, the reinforcement was just no longer there. So I started to really ask my patients on these GLP-1s how they're doing and how they're feeling about their relationship with various substances. And I would say the majority, if not all, really no longer felt the need or desire to pick it up. And I think that's why we will see shortly, hopefully, that some of these medications will actually get approved for substance use disorders, probably starting with alcohol use disorder.
Yeah, it's so incredible because some of these conditions are so resistant to all the different treatments. And so just to have another avenue to get at that is amazing. I know it has not really been like popular in the mainstream, but for a few years here. If we're in obesity medicine, we've used a lot of years. But my question is, do you see after a few years that they struggle a little bit more, or do you find that it sustains for them? And I don't know, maybe based on how many people you've seen, if that's,
For the patients on GLP-1s,
yeah.
the patients that I can recall that have now been on it for 2+ years and they're remaining on that medications, I'm seeing a sustained effect.
Okay.
But I don't want to attribute all of it to the
Oh,
medication
of course not.
because it's like one of those things of you don't know how good you're going to feel until you give it a try.
Oh,
So I think once they put that substance aside and they're losing weight, guess what? They're going back to exercising. Their confidence is going up. Their personal life is improving. They're more productive at work. They're back to their hobbies, activities, and interests where the desire to want to potentially even reintroduce something that was causing so much harm in their life, that also goes away. It's a compounding and additive sort of effect, but it is sustained, I think, while they remain on the medication and continue to incorporate all those other lifestyle changes.
if we can shift gears a little bit to the food addiction side, how
Yeah.
do you distinguish? What are some things you look for that would be a difference between just you enjoy eating a nice meal, something sweet, things like that, versus it's actually become a problem for someone?
Yeah, it's similar to when you look at the criteria for even things like gambling or a behavioral addiction, whether it's pornography, sex, or even a substance. Is it just an enjoyment or is it a compulsion that you can't control?
Mm.
Is it something that you're not fully aware of your consumption? You don't have the ability to control it. Control, I think, is the biggest factor for all of these behaviors and food. And food, for example, is they really have a sense of loss of control of what they're purchasing, what they're consuming, what time frame they're consuming it in. And I think that lack of either awareness and ability to manage it is when it starts to become really defeating and starts to affect not only their mental health, but then physically, whether they start to develop metabolic issues from it or self-image and confidence issues from it. But I think just sort of, hey, I enjoy cheesecake versus I really have a problem with over consuming cheesecake or sugar is being able to say, I'm going to save this for a treat on Fridays versus I need to really have it and I can't not have it throughout the week. And they're sneaking it behind their significant other. They're stopping on the way home from the store and they're consuming it. They're lying about it. They're feeling shame about it. They're feeling guilt about it. Again, a lot of the things and experiences that people feel from any other behavioral or substance problem too.
Where do you typically, let's say someone comes in, let's say they have binge eating disorder.
Mhm.
Where do you typically start with someone? Let's say they don't need inpatient treatment. Okay, we're going to take that off the table for a moment. Where do you typically start working with someone when they come in with us?
Yeah, so in the role I'm currently in, if someone's coming in and I'm screening all my patients for any type of eating disorder or disordered eating behavior, And I do identify, and the patient also identifies and relates with possibly having a binge eating disorder. From a medical standpoint, I do want to make sure that they're medically okay. So maybe some basic screening labs just to ensure, because even though they're not reporting purging or any other compensatory behaviors, just want to make sure. You just never know. What we define as compensatory behavior may be very different than the patient's perspective. My patient tell me, no, I only binge, I only purge once a month. Well, that's still something that needs to be accounted for.
Yeah.
So basic medical screening, looking at other comorbid psychiatric conditions. And then before jumping to meds, because oftentimes this is the first time they're even discussing it.
Yeah.
And the first time they're even identifying it. And it's very difficult. There's a lot of shame that's associated with it, a lot of fear that's associated with it. The first appointment is usually more of a lot of psychoeducation and kind of helping them understand that this is a true disorder and there are treatment guidelines for it. There's help for it. There's support for it. And then I get them connected with a therapist who can really help them and work with them one-on-one to understand what is their behavior like? How is it affecting their health negatively, their mood negatively, their life negatively? And what is it they want to do differently to take better control of their eating habits and even complement that with other sort of groups and working with a specific nutritionist who is experienced with eating disorder. Because if you don't have that experience, you're going to not receive the support that you need. It's just going to be, I'm going to put you on a scale. I'm going to tell you to do X, Y, and Z. Just don't eat too much.
Yeah.
That's the worst thing you could tell a patient. So they need that level of empathy and support and education. And then give them some time to work with the therapist or support groups or even Overeaters Anonymous support group community meetings. And then if that is not sufficient for them to help them reach their goals, then we do explore medications.
Okay. I find, and I know you're probably in a very well-connected center. That sounds like all these parts are integrated, which is a real privilege, right? Do you have any recommendations for people that in most of the country this does not exist? I'll give an example. I actually have a hard time finding therapists that are informed in this capacity because they will often tell my patients, I can't help you with that food aspect. And so is there anything that people can ask or like a way that they could vet the therapist? What would be meaningful when they're trying to seek that person out?
Yeah, that's a great question. And it's unfortunate that everyone in mental health should really be equipped to treat almost any patient to a certain degree. But to
That
say that's just,
assumption, but then I hear
yes,
it too often, you know?
yeah,
Yeah,
and it is a common and real problem, I think. And when I think people struggle because it's not like they can go to their primary doctor and say, hey, can you help me with this? Because they're going to say, I don't know what you're talking about.
right, right.
It's not like, oh, I have a heart murmur. Yeah, here's a referral to a cardiologist. When people are struggling, there are usually experienced social workers that are connected with someone's insurance.
Okay.
And usually they can outreach that specific social worker through their insurance and say, hey, this is the specific condition that I would like some assistance with.
Mhm.
And it's usually the insurance company's social worker responsibility to help get that patient a list of names, numbers, and connections. Oftentimes that may not be possible or might be challenging. There are certain websites and resources where you can screen for what therapists are specially trained in,
Mhm.
but there's a lot of certain treatment centers that focus on treating patients with any type of eating disorder or disordered eating.
Mhm.
And they're all over the country, just like they are for mental health residential programs or drug and alcohol rehabs. In that situation, you could also have patients just do a search for an eating disorder residential program near their area,
Mhm.
because a lot of times those programs, they are bringing in therapists from the community to work at their facility,
Yeah. Yeah.
to run groups and do therapy. They can also provide resources and referrals as well. That would also be a good option.
I'm really glad that you brought this up because I think people think, oh, I don't need inpatient. I think it's more serious than, oh, well, I don't need that level. But it's exactly what you're talking about, which is they will know who to connect you with. I think that's really important. Do you think we need to be doing more screening like in primary care? Who's supposed to catch that there's a problem? Because how would the patient know that this is happening for them?
I think as many touch points that a patient has with anyone in the medical system, there should be a certain level of screening that occurs for a variety of conditions.
Mm.
I would hate to put more on primary care doctors who are already doing so much, but I think for brand new patients, I think basic screening on just how are your eating habits or what is your relationship with food? It doesn't have to be, do you binge? Do you purge? Do you use diet? That's a little too direct. It's almost when I ask them to screen for substance use. Do you use IV drugs? If they say no, that doesn't mean they don't use drugs.
Yeah.
I think we can definitely do a better job screening overall as a healthcare system. But if it is missed at the primary care level, then I do think it's really the job once someone's entering mental health that they're screened appropriately for any type of eating disorder and then appropriately referred and connected with all those subspecialists who can really support them. It's missed in males quite a bit. We know that. They're not asked. There's an assumption that eating disorder is really only associated with females, which is absolutely not true. Oftentimes, we look for the obvious or just the chief complaint of why someone's coming in, but they could really have a real struggle with food or body image that needs to be addressed, but it won't get picked up unless they're asked.
Do men have different characteristics with how they present compared to women? Do they have the same diagnostic criteria or does anything differ?
From what I recall, I think the diagnostic criteria is going to be very similar, but they may tend to have other compensatory behaviors like overexercising
Mm-hmm.
or using sort of workout supplements, high caffeine intake, which are appetite suppressants, but it's not a stimulant. I think they may hide behind maybe a workout regimen or other supplements as a way to either manage their concerns about body image or restrict their food intake. But there's definitely a lot of anorexia that goes on. There's a lot of binge eating that goes on. And they may or may not always have a lot of comorbid depression or anxiety, but definitely trauma can go hand in hand with eating disorders quite a bit. And we see that a lot with our female population.
Do you think if someone, because so let's assume that someone, they're getting in with a physician, they're getting help. Do you think in general there are any top few tips that you give just as far as, things like sleep or nutrition, things where you hit these things with every single patient that they really matter?
There's probably at least 5 or 6 things that I'll ask every single patient, probably at every single appointment,
Yeah.
because mostly everyone who's coming in to see me is coming in because something's gotten to a moderate to severe degree already.
Yeah.
And usually either that primary condition is affecting other aspects of their life or the other aspects of their life are affecting their condition. So some of those things are definitely sleep. I don't mean sleep duration all the time, but
Mhm.
quality of sleep and consistency of sleep. And there's so much focus and emphasis on bedtime when it's actually your wake up time. You should be waking up fairly consistent. But if you're getting up sometimes at 8 a.m. and sometimes at noon or 1 p.m., that's going to affect your mood, energy, concentration, metabolism. So sleep, relationship with food, general eating habits, not just how much you eat, but what you eat. Caffeine consumption, I think that gets missed quite a bit and is a big contributor to anxiety and insomnia, especially with the explosion of energy drinks and all sorts of energy drinks as well.
Mm.
And then I always ask about substances, regardless of why the patient's coming in, including nicotine, tobacco, as well as with the legalization of cannabis and the increased potency. If you just ask drug use, people will say, no, I don't use any drugs. And I'll say, what about marijuana? Oh, that I use. So
Yeah.
I'm very specific, THC or any other licit or illicit drugs,
Mm.
and then alcohol use. And then a lot about just their support system. Who's in their life? Family, friends, spiritual community, because I think that tells a lot about a patient too.
Yeah, these are all really good. I want to talk about all of these, but real quick, the caffeine one, I see that too, because I find that as people get older, I don't know if the caffeine intake is going up or if they're more sensitive to it, but they're getting palpitations, they're getting headaches, anxiety. So many things are happening, yet no one has ever said caffeine could be the thing. And sometimes I'm like, don't hate me, but this might be something that we want to decrease or eliminate. Let's say that you think it's causing a problem for someone. Is there like a certain level where you're like, we want to get you under this?
Yeah, so if you look at an equivalent serving, 40, 60 milligrams of caffeine, depending on how much they're consuming, sort of if I were to just give sort of a general rule or guidance, I tell everyone, let's see how you do with at most 2 to 3 servings before 2 p.m.
Love it. Yeah.
So I go, if you're consuming a lot more than that and later in the day and you're coming to me with anxiety or insomnia, let's start there. And if you're continuing to struggle, then we might need to reduce it more. But I always like to do experiments with my patients. I was like, let's do this together. Let's see how it goes a week with no caffeine, 2 weeks without caffeine. If it didn't make anything worse or better, okay, maybe we'll reconsider it. But generally, 2 to 3 servings before 2 p.m. is what I like to tell people.
Yeah. And I find people know, I mean, we can do I do sometimes genetic testing with people and you can tell if they're a slow or fast caffeine metabolizer, but people typically know this about themselves already. Like I know with me, if I have it past noontime, I'm going to be up at night. And it's
Yeah,
not that I might not be able to get to sleep, but then I'll like get up in the middle of the night. So it's like,
right.
that's not fun. We don't want to do
Correct.
that. But this is I like how you bring up the experimenting with things because I find people are so panicked when we ask them to do new things that I do the same thing. I'm like, let's just try this 3 days, 5 days. What are you willing to do? Let's give it a shot. And then you get to see if it works without this being like a lifetime commitment of getting rid of this
Exactly.
thing or changing it. It's like lowering the bar a little bit for them.
Yeah, absolutely. Absolutely. And there are a lot of studies in literature, gosh, from 40 years ago, even just showing if you're predisposed to anxiety, if we give you an infusion of small amount of caffeine, we will precipitate a panic attack. So those with anxiety disorders are more sensitive to caffeine. And like you said, people know that for themselves. They know how much they can tolerate or whether they can even tolerate it at all.
Yeah, yeah, that's incredible. Um, tell me about with when you say your relationship with food and not only the food but the quality. Are there things that you're looking for, like processed food, or is there sugar intake? Like, is there anything that you're having an ear out for?
Yeah, I mean, when I hear people living a very busy lifestyle, which most of us are these days, and it is about convenience, and especially if you have kids or a larger family, and unfortunately, with the way our access to food is, things that are convenient are usually not the healthiest.
Yeah,
So, if it's coming out of a box or a bag or you're pushing buttons to heat it up, it's probably not going to be the best. And look, I'm guilty of opening up a box and using a
I know. I'm
microwave.
like we're not villainizing all of it.
Definitely not. Definitely not. But I do have patients tell me they're like, yeah, that's all I eat. I eat fast food every single day, or processed food, or microwave food all the time. Or, yes, I need to have an excess amount of sugar or feel like this is what I'm consuming. So I tell everyone, say, let's just look at where we can decrease. Could you introduce a little bit of fruit in there? Could you introduce a little bit more water, less caffeine? Could we just prepare some simple sandwiches throughout the week to replace some of the fast food runs? I'm just looking at sort of red flags of extremes. And with that, I'm looking at what could possibly be missing. I've a few patients, quite a few, who tell me they do not like water. They do not like the way it tastes. They do not drink water. They will drink 5, 6 sodas a day. And so we get creative and say, well, can you get some flavored water? Can you get sparkling water? Can you get something else other than what's coming in from sodas or coffees or energy drinks?
Yeah.
So it's partly looking at what we can help introduce, which will then hopefully help reduce some of the things that are probably in excess.
Definitely. This whole gut microbiome is getting a moment, right? And a lot of it, we know it can affect different medications and how it's working even in psychiatry. The thing that's always shocking to me right now, it's everyone needs to get fermented foods. And I was thinking about it. Why are we so obsessed with making sure that everyone's getting it? It's because a lot of people, like you said, everything they're eating, a can, a jar, like, yeah, there are no microbes because it would mold, it would go bad. I feel like that's one of the reasons why we have to be so fanatic right now on the horn about getting fermented foods because we're trying to bring back in what the sort of like, I don't know, I want to say like sterilization with food, but the way in which we're shipping months on end veggies and things like that, we have to replace that. So it's so interesting when you're bringing this up, the impact on mental health as well. Yeah.
Yeah, I mean that could be a whole podcast in itself about food production, food consumption, food processing. But yeah, if we're ultimately not looking at the actual source of our food and the unprocessed foods, things that are not in mass production or having a long shelf life and stored with sodium, that yeah, we're saying add all these other things, which is not, I'm not saying a bad thing, but you're doing it because you're not actually adjusting or fixing your food sources.
Yeah.
But if we go back to more raw foods and the less processed foods, then I think our guts will get the nutrients we need in an appropriate fashion. But there's definitely a lot of benefits to fermented foods as well. But it's the type of foods and how we're consuming it.
What do you do for people that do not have good support systems in their life? In what ways, like long term, what kinds of areas do you guide them toward to get more help?
It's really challenging because it depends on the population too. So a lot of time, whether they're the geriatric population, they may have different sources to help build a support system, whether it's through these senior communities and activities or volunteering somewhere. But for adolescents, that's challenging because their support system is oftentimes whether it's their circle of friends at school or through social media. And if they're not on social media or not as present as maybe some of their friends, that's perceived and felt like they don't have a support system, and then and then adults in 20s and 30s. So it's looking at what is of interest of yours. I'll tell patients, and when pickleball became a big thing, join a pickleball club, go join a hiking club and try to meet some people in that share common interests. And in the recovery community, that's a great reason why support groups like AA or NA or even OA work is I tell them not because you're working the 12 steps over and over. I go, you build a support system. You build a social support system. They become your friends and your family. You're seeing movies with them, going to lunches, dinners, hanging out. And that's a big sort of component I think that's needed for anyone's well-being is having a social support system.
100%. And it's the fact that you don't have to keep re-explaining yourself to those people, like the friends in your life. You're not like every single time I have to say, well, it's hard for me around this thing. They really get it. But I like this, the finding the shared interests. I find when people work with me, yes, we're working on fat loss and metabolic health, things like that. But universally, pretty much on the first visit, I say, look, because food is not going to play as big a role, we have to build out these other things more. Everyone needs to find a hobby. It's so weird that you think that as a physician, I'm sitting there saying, what hobby are you going to do? What are you going to try? How are you going to get out there? But they end up hiking, they end up meeting different people. Their whole world changes. And that's really hard if you don't have anyone to do that with.
Yeah, it's very isolating and you can feel very alone. So it is, you have to allow yourself to be a bit vulnerable. You have to take risks. And for those that are religious or spiritual, that's a great place to connect with others too,
Yeah.
is through those centers, places as well. Or saying, you know what, I have no idea what I like, but I'm going to give something a try and I'm going to sign up for a class or some sort of project or art class or hobby or sport or something.
Yeah.
And people, they don't necessarily always realize what they enjoy and what they like doing until they gave it a chance. Because you can't just tell someone, just don't overeat or stop eating or stop going to fast foods. That doesn't work. You have to really say, well, what can you do with that time instead? What
Yeah.
can you do that might bring you joy and help you feel fulfilled instead? And unless we really help create that sort of plan with them, they're going to feel lost because all they're going to do is sit and think about what they shouldn't be doing.
Exactly. I heard someone say, we're not sitting there thinking of how to not overeat. We're sitting there thinking, how can I regulate? How can I have fun? How can I slow down to the speed of joy? How can I do those other things? For
Yes.
me, though, it took me years to find, for me, it's like coloring and like junk journaling and things like that. It took me a long time to find because it wasn't just the hobby. It was also what kind of markers they were, what kind of paper. There was a lot that had to get figured out until I'm like, now I'm in the sweet spot for a few years, but that was years to figure that out. I think if anyone's out there, it takes time to
It
find these
takes
things.
time. Oh, yeah. These things you're talking about, sometimes you're going to uncharted territory,
Yeah.
which could be scary, but also exciting.
Yeah.
But also you're taking risks, but you're discovering this for yourself and you're giving yourself time to do it. If you go down one path and you're like, painting is not my thing, no problem. That's the good thing is there's no pressure or expectation. You just start picking up and trying something else or something different.
Yeah, I love that. I have one last question for you. What are your thoughts on exercise? Is that something that is really a mandatory thing that you want with your patients?
Yeah, as we were talking, I realized I was like, there's one more thing that
I
I
knew
did.
you had told me that before, so we got to
Yeah,
bring it
and because I
up.
was like, I definitely left out something. And yes, and the way I frame exercise with everybody, because that word can be a real turnoff.
Yeah. Yeah.
I just tell people, tell me what your movement is. What's your just activity level? Do you have a sedentary job? Do you walk around? Do you walk around the neighborhood? Do you have stairs in your house? And I get a sense of as soon as they hear movement or activity, they'll either tell me, "Oh, doc, I go to the gym 5 days a week for an hour." I'm like, "Okay, great. They're moving." Some people are like, yeah, I'll take some steps or I'll try to walk around. And so right there, I have a sense of maybe there's an element here of limited activity that we can touch on and help them improve.
Yeah.
And so I tell every patient this, the ones that are maybe not having as much movement or exercise as they probably should or would like to, is don't be the person to set the New Year's goal and say, I'm going to the gym 5 days a week for 45 minutes, because then guess what? Friday rolls around, and if you haven't gone, you're like, what's the point? I didn't reach my goal. So I tell everyone, just move. I don't care for how long, how many days, just start moving, walking around, going for a stroll.
Yeah.
And then once you start building up a routine of some sort of movement, then you'll look into, are you a gym person? Are you a weightlifting person? Are you getting a bike ride or a run, a hike? Then you start really setting small and attainable goals and build on it from there. Even if the goal is once a week for 20 minutes, I'm fine with that. If you can maintain that for 2 weeks, great. Add either another day or extend the time. But yes, movement is absolutely essential, I think, for all of us, really, in any capacity.
Yeah. I love how you're talking about it too, because you're saying, look, anything is better than nothing. And like you have to just start doing something in order to figure out the things that you like or not. And it can be intimidating. I do the same thing. I use the word movement because I think that exercise implies mastery, and no one has mastery when they're starting. You got to start where you start, right? One
Yes.
foot in front of the other. Do you think there's anything that we didn't cover here?
I think when it comes to food and relationship with food, it's such a delicate topic because it's not like it's alcohol or heroin or fentanyl,
Yeah.
where it's something essential. Food is essential. You need it to be a part of your well-being, your livelihood, your health.
Yeah.
So it's not like it's something you have to or can remove. You're having to really learn how to incorporate something into your life, but in a way that you feel good about. And it's a stable and healthy relationship, and it's not affecting you, whether it's emotionally or physically. So I think just a reminder to everybody just to be patient with yourself, and that this doesn't need to change overnight. This doesn't need to happen quickly, but to, just like I tell all my patients, just keep coming back. It doesn't matter what's happened or you went one step forward and two steps back. Just keep coming back and understand that some of this, as we know through the science now, is the brain really wired in a way to seek out some of these foods and have a difficult time controlling it. And that compulsion's there. And that compulsion can be broken through appropriate therapy, medications, behavioral changes, but just to be kind, I think, to yourself.
Yeah, that's so good. Being kind, being patient, and the coming back to it. My patients that do the best, they say there's no option to quit. They just know each month they're going to be seeing me. We're going to keep adjusting things, and they always end up in a good spot, but they're willing to keep at it, which is just really hard with a chronic disease. I know you have a hard stop, so I want to make sure to respect that. I definitely learned so much, and we're going to make sure to summarize all of this. We'll have it in the show notes for anyone that's listening. Thank you for taking the time out of your busy clinical schedule to come on today.
Thank you for having me. I really appreciate it.
That marks the end of today's episode. But if you're newer to the podcast, I want to tell you about something that we have, and it's a free podcast roadmap. So this is perfect for any of you that are listening where you want to be directed to very specific episodes. So let's say that you are just starting out and you want to know, what should I do right when I start on the medications? Or you're experiencing certain side effects on the GLP-1s, or you want to know what to do if you're in a plateau, or if emotional eating is taking over, or if hunger levels are high. So we have many different categories of episodes that we've talked about, because there's a lot at this point. So if you want to be able to navigate that very easily, we have it broken down by category, and also the episodes that are there, and we hyperlink to everything. So you can just click on it and find the episode, easy peasy. If you want that, you can go to rentiaclinic.com/podcast roadmap. We'll have it linked right here underneath the show notes where you're listening. And you can go ahead and get that free resource so that it makes it easy for you to navigate, because I know that it's really hard when someone has an established podcast. I am such a podcast fiend, listening to podcasts all day long. And when I find one that I love, but there's a lot that are out there, I am so lost. So I hope that you enjoy this free podcast roadmap. Again, the link to get to that is going to be rentiaclinic.com/podcast roadmap. I hope this is helpful, and let me know if you have any questions.